some pointers to recognize the two key areas of migraine and seizure. It takes normally about 3 to 5 minutes in an optometric exam to test for phoria. Another 3 minutes to test for vergence. Therefore, that's one of the main reasons why that test is not done. So as parents, and so, by the way, all my patients that I've seen, they went through their medical workup, so I'm not too worried when I see my patients. So my job is to identify optometrically whether or not there's any abnormalities. They don't have structural or neurologic problems. And so if you keep looking in that area, you won't find anything wrong. These are some of the other diseases that's been associated with Asthenopia or eye strain are headache, migraine, as I've mentioned, dyslexia, autism, Aspergers, and seizures. Yeah. Okay. So, what's common across all these patients that I've found through 18 years of practicing and doing the same test on every one of my patients. I know the norm. I know the normal patient versus the abnormal, and so the main thing is they all have Asthenopia. So let's go through with some examples. For example, I've seen a few Aspergers. I actually have not seen autism. They never showed up in my 18 years of practice, but they all have the same symptoms and signs. They don't look at you. So a couple of the ones I have seen, right away, they show convergence insufficiency. So I trained one of them, and the mother said, mother was very happy that now basically the child is back to normal, functioning normal, back in school and at home, socially and in school. Okay, as far as ADHD, what I found is that ADHD in child, number one cause is convergence insufficiency. The main reason is very obvious. They can't convert. Their short arms, their body's small, so they have to converge really close. And so that's, to me, that's the main reason that it shows up highest. CI is very prominent in kids. Whereas in adult, I've seen several adults with ADHD, and number one cause there is hyperphoria, consistent with what I've seen across the population. And among other deviations, not really significant exophoria, but the main thing I'd like for you to have is some way of testing hyperphoria. You cannot recognize a vertical eye deviation. The only way of recognizing vertical deviation is by the posture of the patient. That's the only way. Because if one eye is higher than the other, that's not phoria. In phoria, we're talking about two abnormal eyes. Strabismus, if you see one eye higher than the other.
Next slide. Next slide.
Yeah, next slide. Okay, so let's go right to the key questions. These are things that I've used personally myself. So the mission of an optometrist is to provide you with healthy vision, but comfortable, clear vision, number one, followed by comfortable binocular vision, number two. So this is the same chart as before, but this is how we test for, the best way to test for hyperphoria. Let's put the patient behind, and that's the handheld version. So if you deal with a lot of seizure patients or migraine patients, 1.5 is not reproducible. The most reproducible is the phoropter. So that's a handheld version of the Risley prism. And so if you're dealing with seizure patients, they're going to be in the 4 to 6 range. You'll be able to pick up a lot of approximately what range that is. So you actually, because of the threshold that I've already established that I've seen, you can actually help these patients just by holding a handheld and putting it in front of their eye, and they're going to feel relief. By the way, anytime I prescribe a person, I first hold a trial person in front of their eyes to make sure that they feel comfortable, and it's always dramatic improvement in their sensation almost instantly. The handheld retinoscope. That's the jewel tool for the optometrist. Normally, you come to an optometric office, you get put behind a refractor, auto refractor, and that gives you an estimation of what the refractive power is, and then you So a real good optometrist, if you see him after you get the data and they bring you back behind the phoropter and they shine that retinoscope on your eye, he's double checking your numbers from out there, because he's relaxing your eyes more. Sometimes when you put behind a auto refractor, you're going to have influence like peripheral vision. So it's not, or accommodative access. So when you see a doctor use a phoropter for an eye exam, chances are he's going to be double checking for you. So that's one hint of looking for a great optometrist or ophthalmologist. Okay, I designed one test for everybody. Migraine, seizure, and all these asthenopia conditions is everywhere. Every part of the world. I can go to church and they'll say, wow, so many people have migraine, and now they're all healed. Okay, so there's different. You're going to encounter migraine, all these neurologic symptoms. So here's the way to check for hyperphoria. Get a picture, split it in half, create a vertical separation, and if you are right eye, if it's important to identify, is it right eye hyper or is it left eye hyper? Because with that information, you can find the preferred gaze versus the gaze to avoid. The eye tracks, it's constantly in movement. We got smooth pursuit, saccades. So, vertical deviation, horizontal deviation, it can occur. And the brain is constantly trying to fuse that image. So, a person with right hyperphoria, right eye is higher, the image will be lower. And so, if you have right hyperphoria right now, if you look at this image, you won't, first of all, you see, I didn't get a chance earlier, but the lower image shows horizontal deviation, and you'll notice that most people are not sensitive to these, even though it's split quite big horizontally, because the eye has alternatives that adjust for horizontal deviation. They use accommodation, and where eyes are constantly accommodating our focus, we use our lens to bend. So that's the main reason why we don't have symptoms with horizontally. Vertically, there's no alternative except for head tilt or head turn. Okay, so next please. So right hyperphoria patient sees the image lower. Now notice this picture here, the right side is higher. So if a person likes to naturally like to see things lower, if you put it up higher on the right side, they're going to feel strain. So this is how you can check to see whether or not it's a right hyperphoria or a left hyperphoria. This is the simplest way, to do it. So if a patient says to you, and by the way, I did test this on a few people, and it works. And I can explain it, why it works. Okay, so they're going to look at across the previous picture and say, when it comes to they'll say, oh, this one bothers me much more than the other. If you ask them to compare the two pictures. This one, again, is convergence. You want to be able to, everybody should be able to do this on their patients or their family. Just bring it up to the nose and make sure the eyes comes in together all the way to the nose. If it doesn't come to the eye, consider their age. If it's a child, most children I've seen are able to come right up to the nose. And so with that ability to converge, they'll have less symptoms. You may have headaches, migraine, and that disappears as you get bigger and taller. This is the way to test for dominant, and this is how I start my test with every patient. And the reason, my patients don't know it, but and I'll tell you why it's important. So just make a circle and test a couple of them. Make sure they're consistent. If they're consistent, it means that they're really, really right eye dominant or left eye dominant. Otherwise, you know, the dominant thing is not as important when I finally refine the refraction. So the two things most critical are refractive test to an optometrist and binocular test to an optometrist who has Asthenopia. With refraction test, by doing this, you know which one is dominant. And then, so I would recommend that you just check their vision. Pull out all physicians have this. Just get a near point card. See where a child holds the card, or a regular adult, you know. And then check right eye vision, left eye vision, and that's for close. You look at their posture, you know, tilting their eyes. You know, if they have abnormal posture, they might be compensating for their Asthenopia. And so for distance vision, we're mainly concerned right now for refractive test is distance vision. Normally, what I found among my migraine seizure patients, they want a total overall balance in their vision to you know, that best prevents symptoms. So it's recommended that you put, after refraction, one eye is going to might see slightly clearer than the other. Always put the dominant eye to be clearer. And the way to refine that optometrist is they let you look at two sides of one baby with one side red, one side green. If you see into if you say the green side is slightly clearer than red, he's putting you into slightly minus. And that could provide the additional comfort to make your vision feel more comfortable. So dominant eye, so in your people that's not in an optometric setting and you want to help your patient or your family, check their dominant eye, look at a distance, just say which side is clear. And then you look and then say, and if you've noticed that they say, oh my other eye is clear. Take them back to the optometrist. Say balance, you know, don't be afraid to talk to the optometrist. Just say, hey, say, hey, my eyes, I heard somebody say that it's better to leave the dominant eye clear. The dominant eye is important because it's the dominant, it sees first, it's the eye that's responsible for tracking binocularity. And so a lot of people, when we decide, when you reach over 40, 50, and now you're presbyopic, this is how we determine whether or not you'll be a good candidate for monovision. Because if you have really dominant right one side, you'll be great on monovision contacts. But that same concept for a child, the child wants to see clear in the dominant eye. So even if your non-dominant is clear, you won't have symptoms. But if your dominant is not clear, you will have more likely to have symptoms. Okay, that's basically what you. The key for children is, do you enjoy reading? Almost every Asthenopia patient, any child, reading. If they say they don't have reading, they'll have two things: either CI or hyperphoria. Okay, and then for binocular tests, the most critical one is the Paris 3 test. Paris 3 steps test. This is a test that's used by physicians to identify the strabismic muscle to do surgery to correct the deviation. But I use it for four-year patients because it makes sense that for them to identify which eye is weak and needs surgery, it makes sense that four-year, because they're identifying basically the function of the eye. Like I have found, I don't need to, but I have found basically the superior oblique muscle is which is the most common, and that's the fourth nerve sits in the back, and you know it's the longest route to the midbrain. By the way, convergence is also in the midbrain, and the convergence system is very plastic. That's why we can train easily with near point tests that you can do vision training. I would recommend doing 30 times, 10 in the morning, 10 in the afternoon, 10 in the evening, 30 times a day, slowly, keeping fixation. And after 3 months of of continuous training, you should be able to expect 2 to 3 inches of improvement in their convergence, which will decrease the symptoms. So so
That's right.
so if you're, can you go back to the other? Okay, this is not as important. So on the top is all right hyperphoria. The right eye is higher, left eye is lower. So if it's greater, if it's more deviation or they don't feel worse on left gaze, the next thing you ask them is it, or you can see the optometrists were doing cover tests, or the ophthalmologist, they do cover tests to see which way the deviation is more. But for you, you would just say, you say which way is more strained to you, a right head tilt or left head tilt. Usually, most people comes in with a left head tilt. That means they have a right superior oblique weakness. Well, most people come in with a left head tilt, and so that means the preferred gaze is left tilt or right left gaze. Left gaze means looking to the left, and oh, I'm sorry. Greater deviation on left gaze, so he's going to look towards the right. I'm sorry. This is what's important. See, turn. Okay, a ophthalmologist will recommend surgery to prevent you from tilting your head too much. That can cause spinal degeneration as you get older. So they'll do UM surgery, and depending on the region of the world, some do it, around age 3, 4. Some in the U.S. we do it around 5 to 6 age before we do surgery on EOMs. And so let's focus on the.
Next slide.
Okay, next slide.
I think we can go to this.
When you're uncertain, these things are the different triggers of common triggers. Just ask them to look at different things that really can cause strain to the eye. You don't need to focus, but if you see somebody is having symptoms, ask them to cover one eye. By covering one eye, the strain disappears. Because it's no longer a phoria problem when you cover one eye. And that was the question that. So every pair of glasses, whenever you see somebody wearing glasses, minus lens is always thicker on the edges, top or bottom or the edges. And that's how you can create prismatic effects. If you wear your glasses tilted this way and you put the optical center is right in the middle, but if you make it so that you're looking out through the top portion of the glasses, you're going to create base down prism effects. If you have a minus, wearing a minus. So right hyperphoria patient, if you're in a remote part of the world and you have no medical care, but you happen to be there, just say, you can see that it's thicker on the edge. You know he's wearing a minus lens. Tilt his glasses down this way. So right hyperphoria likes to see lower, but now if you tilt your glasses down here, you put his optical center, you're putting his view into the upper part of the lens. That is base up prism. And now he's got a natural base up prism effect. It's like you giving him a prescription. All he has to do is just make sure it sits lower so that he's constantly looking on the through the top portion of his glasses. And the opposite would be the case for if he was wearing a plus lens. Plus lens is thicker in the middle and thinner on the eye, so you can see how you can design. So that, just remember, so the concept can help you understand why people have symptoms, and you can actually help them without any tools, just by knowing some simple optics.
Time.
Opticals. Okay. So
conclusion.
Okay. The conclusion is that there's evidence that optometrists can identify after medical workups, and if you haven't had any success with your migraine, seizure, or Asthenopia patient, get them to an optometrist and say, test foria for a vertical foria distance and near, and make sure they don't, you can do convergence insufficiency tests yourself, and then help them, guide them from there. And chances are you're going to relieve their pain and their suffering. And there's no side effects, and we all want no side effects. And that's something new. Okay, thank you. Okay. Thank you for your time.
Otherwise, the letter